Nazareno Gerald, ladies and gentlemen, I'm going to give you what I hope is a sort of complementary view and take a similar but slightly different view to Nazareno, and my view is from outside the European Union. I think we should first of all ask the question, because Nazareno has spent some time explaining, in a way I absolutely agree, that prognosis, severity is extremely difficult to assess reliably. When I tried to do this some years ago, I went to the oil industry in London and said to BP, how do you do it? Because the oil industry have the most experience in assessing risk, because the number of barrels of oil they're going to sell varies hugely and unpredictably. And in the end, despite everything they've got, the answer to all of my questions was about uncertainty. And I think that this is largely what this is dealing with, and one should not mislead anyone into thinking there is any certainty about prognostication. Let us first of all just review what the purpose of all of this is, because unless there is a very good but useful purpose and it can be used, there's no point in the risk stratification. The purpose of the risk stratification is to inform evidence-based treatment strategies. We're going to come back to this in a moment, and the significance of that, and obtain best outcomes for patients. And in the end, it's how the patients are that is going to matter. Now, bear this in mind as the critical test as we go through, because like an investigation in medicine, there is no point in performing an investigation if it's not going to alter treatment. So the first thing is, why have a risk score at all? Why not just ask doctors what they think the prognosis is in the patient? And this is the work that Nikos Christakis did just before he went to Harvard, and when he was spending some of his time in London with us, looking at prognostication in seriously ill patients. And what you see is that physicians are, by and large, over-optimistic in prognostication in terms of death. A few are, 16% are, 70% are under-pessimistic. And physicians work by self-fulfilling prophecies. We decide as physicians what is going to happen in our head, and then we arrange everything so that that's what does happen, and that's what we know. The best thing to say is that you can just ask Nazareno, because the greater the experience of the physician, the greater the prognostic accuracy. But if you really wanted to know the prognosis in a patient, you got somebody who'd never met the patient before and brought them in and showed them the patient, and they would tell you the prognosis more accurately than you can. And crucially, and this is the problem in a chronic disease where you get to know your patients, is the stronger your relationship with them, the more you extend prognosis into the future. So if physicians can't do it, perhaps the nurses can. Oh no, they can't. Sorry. The nurses are here, the actual prognosis is here, and they underestimate mortality by 20%. So there's not something, it's not that there's a problem with physicians per se. Healthcare professionals in general can't get the prognosis right. And then we've also got the issue that we're dealing with a cardiovascular disease. And if we go back to the support study, the study to understand prognoses and preferences of outcomes and risks of treatment, which was carried out in 5 academic medical centers in the United States of America at the end of the 1990s. It was funded to $28 million. It produced over 200 papers, and the primary outcome was announced on the front page of the Wall Street Journal. This study is really important because we live in the world here of cardiovascular disease, this red line here. And what this is doing is asking the physician the time they think, at this point, this very day, when you show them the patient, how long do you think this patient will survive? And then plotting this against the actual survival time. And what you see is that cardiovascular disease is by far and away the least predictable disease. And some of this, of course, is related to the fact that patients drop dead suddenly. So we can't do this by asking the doctor, by and large, and we have chosen the most difficult type of disease to try and predict prognosis in. So the guidelines, as you well know, take this view, and crucially, they're looking at the risk over the next year. But of course, the patients are looking at the risk over the next few years. Their purview is greater. And furthermore, in addition to what Nazareno has said about this, I think there is something about the Mediterranean diet in this, and that is that there are a number of components, and we need to know when we use this score that these components work well together as a composite to predict outcome. And the only way to do that would be to decide, and we'll come to the answer at the end, because there is an answer to all of this, you'll be pleased to hear, but you would have to put all of these together and prospectively evaluate this, which is what Nazareno has called for, and I absolutely agree, but you would have to choose the right mix in order to do this. Now, having said that, it's not as easy as that, because in reality, you find that various measurements in a given patient are missing. And so there is a huge issue of missing data in an individual patient. And although we say take the one that is furthest to the right as the actual risk, the difficulty becomes is that in practice, if there was only going to be one at the far right and you didn't measure it that day and you measured another one, they might come out much further to the left. So there is all sorts of biases even in trying to do it in a patient. And Nazareno's talked about the evidence for these different measures, but here you see it. And the general impression has got to be that there are actually a remarkably small number of studies that provide this information. Some of these measurements are based on often individual studies. There's nothing wrong with that, it's just that there is not the weight of evidence. Now, these measurements that are chosen are part of expert opinion. They go back to 2009, indeed, in fact, before that, but it's very much the same in the United States of America. It was very much the same at the World Symposium in 2013. This is what you would want to achieve. But of course, just because you can alter them doesn't mean to say you can improve prognosis. This is something Nazareno's pointed out. I would just stress it again, that we have seen in cardiovascular medicine, and I'm sure many of you will agree, in the last 20 years, trials where endpoints have been put up that can be improved, but they do not alter prognosis. So just altering biomarkers and improving biomarkers is not to say that anything gets better for the patient. The risks, the prognostic factors, if you like, in the table are not all the prognostic factors. There are plenty of other prognostic factors. Let's take over here demographics. Now, the demographic is important, male, female, age, for example, because in a risk classification, they are immutable. You can never change them. You can't make people younger, at least not yet. And the etiology of PAH is also immutable, because once the patient's got that diagnosis, that's where they're going to remain. And then, of course, there are all sorts of other things. There are there's more pathological things down here one could put in. I'm not proposing putting those in. But crucially over here, there's the issue of patients, how functional they are, what they can do, their frailty, and the major effects of things like depression, which, of course, in heart failure increase mortality. And then there are measures of end organ dysfunction, which haven't been included. And crucially, there is, I think, increasing evidence that stability over time is a predictor of outcome. So there are a number of things. So let's just go back to where we started for a moment and say, well, if we're going to do a risk assessment, what are the treatment options based on that? Now, if we start at the beginning on our baseline risk assessment by using all of the oral drug combinations in combination, that means that the risk assessment in terms of available treatments, at the very least, would be parenteral prostanoids and lung transplantation. And that would depend on whether the patient who is sitting in front of you would ever agree to parenteral prostanoids and lung transplantation. And of course, as we know, not everyone wants to do that. So how do other diseases do it? And I would go back to my heart failure days, and here are the latest ESC guidelines in heart failure, and there are 9 really interesting measures of risk in heart failure, and none of them are recommended in the heart failure guidelines. The modern approach in heart failure, you will see here, is symptoms, still symptomatic, do something, still symptomatic, do something, persistent symptoms, continue to do something. So heart failure is managed on the basis of symptoms. Perhaps that's something we should consider. Let's have a look at a patient. This is the reality, and I don't know how many of you have actually tried to use this formally when you are assessing a patient. But this is the reality of what happens, and it isn't simple. So here is a 32-year-old female who presented about 18 months ago with a 9-month history of worsening breathlessness, and at the point of being seen for the first time, here is her risks. And you can see there is a lot of red here. She had rapidly advancing breathlessness. She's in functional class 4. She has a lousy cardiopulmonary exercise test, much worse than the 6-minute walk test would have you believe, bad echo and hemodynamics. And after 4 months treatment, and you would think on the basis of that she should have prostacyclin, but she says, no, I'm not going to have prostacyclin, thank you very much. So she has initial oral combination therapy, and here she is 9 months later, and sorry, 4 months later. And you can see now that there is improvement, but improvement in what? We've moved from red to yellow, but yellow is still unsatisfactory, and so she requires another treatment. So that's a bit more straightforward in this case because everything has moved in the right direction and we're making progress. Whether we'll ever get to green, I don't know. It does go on improving over time, but it never gets completely green. What this warns you about is that, first of all, symptoms alone are in the green category. So unlike heart failure, they're not predicting risk. And if you leave her alone and just go on symptoms in this patient, you will abandon therapy and leave the patient at risk, we believe. The 6-minute walk test on both occasions was better than the cardiopulmonary exercise test, and we're well aware the 6-minute walk test may, in certain patients, particularly in people who've been fit and in young people, may give you the impression that things are better than they really are. And so I would argue that, and this is inevitably a difficulty with this, that each of these measures is not actually of equal value in every patient. And which measure is of value in your patient is individual to that patient. Here's another patient. He was in the ward a couple of weeks ago when I was on the ward. 28-year-old, 2 years worsening breathlessness. He presented a year ago with repeated syncope, an exercise test 144 meters, a BNP of 822, a large right atrium, which was about 29 centimeters squared, and a very small pericardial effusion. He had a mean pulmonary artery pressure of 79 millimeters of mercury, a right atrial pressure of 9. All right? 79 millimeters of mercury, right atrial pressure of 9. He starts on initial combination therapy, and the long and the short of it is a year later, this is where we are. The mean pulmonary artery pressure, which you note is not a prognostic marker, has dropped from 80 to 60. So he's still got fierce pulmonary hypertension. The right atrium, however, remains enormous. There is, I would say, trivial pericardial effusion, but there's not no pericardial effusion. And, by the way, we have done a saturation run. We have done echocardiography. There is no evidence anywhere of a sinus venosus defect being missed. The BNP is just a little bit above 50. The peak oxygen consumption is 16.5 mils per minute per kilo. That's in the green zone, but the predicted of 55% is in the yellow zone. And his ventilatory efficiency is in the green zone. So look, and because both are absent, I've highlighted both. Okay, so look, if we could get rid of the yellow there, if you agree with me, we could move peak oxygen consumption over to the green zone. The BNP is only just above 50. So perhaps if we repeat it again, we might manage to get it below, get it into the green zone. Then we're left in this patient with an unexplained large right atrial area and a trivial pericardial effusion. When on echocardiography, when the cath was repeated, the right atrial pressure was 4, and on echocardiography, the inferior vena cava collapses with sharp inspiration. So the right atrial pressure isn't large, he's just got a big right atrium, and that's it. So I suspect, although he appears red, he's probably much more green. So this issue Nazareno has dealt with here is that we are aiming to lower risk, but I can't promise you that lowering risk means that we have improved outcome. Now, the other major issue with all of this is comorbid disease. And comorbid disease will inevitably affect risk assessment because there is no way of assessing with comorbid disease, and that's the problem. When is comorbid disease the disease, and when is it comorbid disease? But there's no way of assessing how much of the breathlessness is in a patient is related to the pulmonary arterial hypertension or the COPD, or for that matter, anything else. And this raises the additional question, because remember, we're doing this in order to alter treatment, that a Cochrane review of this has shown, not of pulmonary hypertension, but in general shows that there is uncertainty about the effectiveness of interventions in multimorbidity, which is the trendy term for having comorbid disease. So this presents a problem. And Sean Gain has already showed you the ambition criteria, and this represents this complex interaction that this is comorbid disease, and patients are being excluded in the final data set of ambition for some of the comorbid disease, but this comorbid disease also causes other forms of pulmonary hypertension. So it certainly adds to the complexity of how comorbid disease interacts with risk assessment. And similarly, Sean talked about how normal spirometry can be highly misleading. When it comes to other forms of pulmonary arterial hypertension, it turns out, of course, that, and we know different types of PAH have different survival. Here in scleroderma, for example, we know that this is, people at particular risk are old men, particularly if they've got a very high right atrial pressure and pulmonary vascular resistance. So you can identify different risk in different forms of pulmonary arterial hypertension, and this traffic light system is a proposal designed for Eisenmenger's syndrome, where you see one of the factors that is being considered is iron deficiency, which is clearly not in our PAH algorithm. So there is the potential for assessing risk in different forms of pulmonary arterial hypertension, in different people of different ages, and it starts to become a little bit more complicated. So what are the alternative strategies? Well, Nazareno's talked a little bit about the obvious one, which is to create a risk score. And I think the reason REVEAL goes to such extremes is in the hemodynamics, for example, such that, as the late Robin Bast used to say, what the risk score said was obvious. You didn't need a REVEAL risk score to determine what the risk of your patient was. It's using a stepwise model, so you get this very severe black and white approach to what is a risk and what is an improvement. And of course, the risk scores provide a range, so you can see as the risk score calculated goes up from 0 to 22, how that range progresses in terms of mortality. Now, I would be interested to hear from the audience, despite what Nazareno has said, as to whether you prefer a traffic light system or whether you prefer an actual number. Remember, the number falls within a range, so this is a bit like the traffic lights, except it's split into 5 groups. And I would really be interested from the practicing clinicians to know what you think is the ideal. REVEAL was not designed to be used serially, but it was used serially, and in this demonstration where the risk score changes by by 5% or more after 1 year, it was possible to show a realignment of the risk score, but there was still an important effect of the baseline risk score. So it is, in principle, possible to follow serial risk and alter it, but this is a very limited study. And then the French group have also demonstrated, because there are important differences in the REVEAL population with Europe, that applying the French equation, which is based on gender and walk test, is completely different score to the REVEAL score, and you get actually what I'd have to say is a remarkably good correlation between the scores, suggesting that there is the possibility of extending this across geographic populations. So the big problem with this sort of registry stuff, creating scores from registries, is primarily the immortal time bias that patients have to survive to get into the registry. So that has to be taken account. There is always the problem of missing data, which we have in clinical practice, but also in registries. There's a lack of serial data in some registries, and there's still the question of generalizability outside the registries. And therefore, from my perspective, I would have to say the data about prognosis is still too local and not global enough. So for that reason, I would propose that what we need in pulmonary arterial hypertension is a large database with phenotype information. And really what's needed here is a meta-analysis of both registries and patient-level clinical trial data. And so at the end of this, I'd be interested to hear from industry if that is something that industry is interested in providing data for in a large database. And this would be controlled by machine learning and the new techniques in information technology to manage big data. This has been done at the London School of Hygiene and Tropical Medicine by Stuart Pocock in the MAGIC score for heart failure. This involves just over 39,000 patients from 30 registries, 6 of which are clinical trial databases and contribute 24,000 patients. And this is able to provide 1- and 3-year all-cause mortality. The score, you will see, does include immutable things like age and gender. It includes comorbid disease, which I think needs careful consideration in PAH. I don't think there's enough data for it yet, but it's something we should consider having. And you'll see it also includes drugs, as well as evidence of end organ dysfunction. So it does take a very different approach, but it is possible using a proper statistical analysis of the data in these patients to reach this, and you can see the risk score is split this time 6 ways. The data is perhaps not surprisingly very good between predicted and observed because one is using patient-level data in a large meta-analysis and the data is global. So my conclusion, ladies and gentlemen, is a risk assessment tool is better than asking the doctor. The doctor's not always right. A selection of risk assessment tools combining multiple measurements are certainly needed for PAH. Different forms of PAH may require different assessments to describe severity. Comorbid diseases add a whole problem, another level of challenge to assessing PAH severity, and I've discussed the future alternative, particularly a proposal for the future for a meta-analysis of databases. Thank you very much for your attention.